My name is Samuel Ralph. I'm one of the family physicians here in Grand Falls, Windsor. I'm listed with the Department of Family Medicine and Obstetrics. And today we're going to be talking about managing obstetric emergencies in rural and remote areas. Objectives for today, we'll talk about obstetric hemorrhage, the differential diagnosis for an antepartum hemorrhage. Most common causes of these are things like placental abruptions, placenta previas, and a vasa previa. We'll talk a little bit more about this stuff a little later on. The four common causes of a postpartum hemorrhage are the four T's: tone, tissue, trauma, and thrombin. And we'll talk a little bit about management of a postpartum hemorrhage. There's mechanical, medical, and surgical management. And the other most important thing for folks in the periphery is when to transfer to a different health center. Okay, antepartum hemorrhage, one of the more common ones you'll bump into is an abruption. Usually painful, not always, and sometimes, in about 20% of the cases, bleeding can be concealed. So you can have a patient present with just plain old abdominal pain, and that's an abruption. You always have to think about it. Things you need to be thinking about are risk factors. Things like hypertension, if they have pregnancy-induced hypertension, if they're smokers, if they're taking medications, amphetamines, cocaine, if there's a history of bleeding disorders. And that one can be tricky because there's not always a clear history. If there's any history in the pregnancy of intrauterine growth restriction, if there's a history of stillborn, previous abruption, like a lot of things in medicine, if you've had it once before, that puts you at a higher risk for having it again. And then there's also trauma, falls, motor vehicle accidents, somebody slips down the stairs in the wintertime, those sorts of things. So if you look at the examples on the screen, you can see what concealed bleeding looks like. That's hiding behind the placenta and there's nowhere for it to be seen. When you look on the to the right-hand image, when you see visible bleeding, you'll see how that actually works, and bleeding will come down through the cervical os. Things to look out for. Look for a non-reassuring fetal heart tracing, and the things specifically you're looking for those sorts of things are if there's fetal tachycardia, loss of variability, decelerations. Not always obvious, but you need to look for it. So pain plus or minus bleeding with a tender uterus. Things to keep in mind: if somebody has a posterior placenta, they don't often present with abdominal pain, they may present with back pain, so that's something to keep in mind. And that can be confusing because lots of pregnant women will come in complaining of low back pain just because they're pregnant. So you always need to be thinking about that sort of things. If you've got an antepartum hemorrhage and the patient is premature, always think about transfer for postpartum access, pediatrics, neonates, that sort of stuff. Think about steroids if the patient is less than 34 weeks along, and think about magnesium sulfate if they're less than 32 weeks along. And if you haven't done this in a while and you're not sure, call us, get the support, and then talk about transport. Placenta previa is usually obvious on an early routine ultrasound, the ones that are done at 18 to 20 weeks. Placenta never moves down, it always moves away. So if you've got a normal 18-week ultrasound, you're not going to develop a previa later on. But if you get one noted on 18 weeks, then that person needs follow-up with serial ultrasounds to ensure it does move away. And beware in the pregnancy, like we said earlier with the low back pain, if you've got a posterior placenta, fetal head can mask where the actual placenta is. There are risk factors, but the thing to keep in mind is if you've got a previa, don't do a PV exam, and if you're not sure where the placenta is, don't do a PV exam until you're sure. And if you do have a patient with a placenta previa, if it's a complete previa, that's a C-section delivery. Those sorts of folks need to be followed by obstetrics and gynecology. If you've got a low-lying placenta that's less than 2 centimeters away from the os, then these folks can be attempted vaginal delivery, but it's usually done as a double setup in the operating theater. And if you look at the images on the slide, you can see exactly how placenta previa works. If it's persistent previa at 32, 34 weeks, our personal policy is that the patient be managed within or near a hospital that's got 24-hour access to an OR, anesthesia, pediatrics, blood bank, and the ability to do a C-section. In central Newfoundland, this means patients got to be close. Windtown, Grand Falls, maybe as far away as Bishops, but that's about as farther. And if a patient's going to do things as an outpatient as opposed to be admitted, they need to be aware of how and when and what sort of risks. Well, oftentimes we'll tell our patients, if there are known placenta previa, if you show up to the hospital for anything, the first two words out of the patient's mouth should be placenta previa. Tell the nurse, they will know what's going on. And if you've got patients who've had a history of a prior C-section, Those are things to look out for because you can get an improper adherence of the placenta to the uterus. You can end up with the incretas, percretas, and the accretas. And the best way to describe those is if you look at the image on screen, they'll show you exactly where they are. The accreta is adherent to the wall, the increta starts to invade through the myometrium, and the percreta starts to invade out through the myometrium. And these sorts of ones can get increasingly troublesome causes of postpartum hemorrhages, and these are the ones that need hysterectomy and surgical assistance. Vasoprevia, that's when you get a filamentous insertion of the cord and the actual placental vessels will go across the cervical os. You can have a look at the pictures on the screen and it'll give you a nice clear idea. You've all seen a placenta with those large venous blood vessels. When that goes across, there's a great risk there for a painless hemorrhage. So if you know the patients have those sorts of things, those are ones you want to have come into the hospital before labor starts if we can help it at all. Now, how do you define a postpartum hemorrhage? Definitions are a little bit arbitrary. Generally speaking, anything more than 500 cc's for a vaginal delivery and anything more than a liter at cesarean section. Sometimes it's hard to estimate this sort of stuff, so when I'm teaching the ALSO course, I explain it to the candidates doing the course. If you take 500 cc's of water and just pour it on the floor, you'll get a puddle that's around 3 feet in diameter. So if you've got that much blood on the floor when you're doing a delivery in your hospital, well, that's a postpartum hemorrhage. Vital signs and symptoms will guide you, but lots of times, particularly in pregnant women, vital signs can be normal for even when the hemorrhage is going on. So you need to pay attention to the blood volume, not just the vital signs you get. Best way to look after postpartum hemorrhage is active management of the third stage of labor, and we do that routinely. That's continuous cord traction. Every patient gets parenteral oxytocin with the delivery of the anterior shoulder. Then patients will get a shot of oxytocin, and we always do fundal massage. This will reduce blood loss and postpartum hemorrhage compared to passive management. When you are doing this sort of stuff, it's the usual trauma and resuscitation protocols. You use airway, breathing, circulation, supplemental oxygen, baseline vitals, but you have to do frequent updates because things can change quickly. You always need IV access, largest bore you can get in there. And if a patient's at a higher risk for a postpartum hemorrhage for whatever reason, think about putting the IV access in before the delivery actually occurs. And one of the things we also do is bimanual massage of the uterus. And if you refer to the diagram, there's a fair bit of pressure going on there. You really have to be able to reach your hand in and get good compression. And that's really important in patients who are heavier. If they've got obesity as a risk factor, that can make uterine massage a little more difficult. So you really need to be aware of your anatomy. Think of the etiology, the 4 T's. Tone is uterine atony. And that's the most common cause. That's almost 3/4, 70% of patients, uterine tone. Tissue is retained placenta, so every time you deliver the placenta, have a look and make sure it's complete. Trauma, lacerations, uterine ruptures, or uterine inversion, not always obvious, you have to look. And thrombin, those are the disorders of hemostasis, the blood clottings, the patients who have histories of von Willebrand's disease and those sorts of things. Medical management of uterine atony is oxytocin. Everybody gets 10 units when the anterior shoulder delivers, but you'll put 20 to 40 units in a liter of fluid, and it's in a pressure bag, and you run that in as fast as you can. Set up a second bag and run that in at 125 to 150 units an hour as you need it. Prostaglandins would be next line. We use Hemabate. There's 2 ways to give the Hemabate. It can be given IM or intramyometrally, whatever you're more comfortable doing as long as you can administer the medications. 250 micrograms IM every 15 minutes. You only need to remember the dose for testing. It's 1 ampule. Whatever comes in the bottle, give the whole thing. Other options will include misoprostol, 800 to 1,000 micrograms, and that can be done rectally. And if you have to, you can also give it 200 micrograms PO. PO doesn't work quite as fast. Ergot used to be on our list of things we'd use, but it's not readily available. Nobody stocks it anymore. So it's more of historical importance. Surgical management of uterine atony. This is where you get into the gynecologist's territory. You talk about uterine artery embolization and laparotomy. They can ligate the arteries, B-Lynch compression sutures. This is more for information. This is not something you're going to be doing in the periphery. This is something the gynecologist will do in our OR. And as a last resort for a hemorrhage, a hysterectomy. Obstetrical hemorrhage is a significant cause of maternal mortality around the world. 287,000 maternal deaths in 2010. 25% of those due to bleeding. So that's 70,000 women can hemorrhage to death because of pregnancy, or in pregnancy because of a obstetrical hemorrhage. In Canada, maternal mortality is 12 per 100,000, and that related to 46 pregnancy-related deaths in 2010. So if you can stop the obstetrical hemorrhage, that's a lot of good you can do. And be prepared, because like we said earlier, these things can sneak up on you. Presentation can be subtle. It can be a slow trickle, but over time that can add up to more than a half a litre of blood for a vaginal delivery. Be aggressive with resuscitation. If you're suspicious, if they've got risks for postpartum hemorrhage, then have the IV access. Know where the hemobate is. Have it all ready. And if you're in a smaller centre, be prepared to have a transfer going. Get the ambulance ready. Have your team ready to take them with.